The Code of Practice for the Diagnosis and Confirmation of Death in Children and Infants older than 2 months of age follows the recommendations of the Academy of Medical Royal College's guidance published in 2008. This code endorsed the guidance published in 1991 by the British Paediatric Association, the professional representative body of paediatricians in the UK, which became the Royal College of Paediatrics and Child Health in 1996. In 2015, the Royal College of Paediatrics and Child Health produced recommendations for the diagnosis of death by neurological criteria in infants. These recommendations are applicable from 37 weeks corrected gestational age to 2 months post-term. At present, due to immaturity, it remains inappropriate to diagnose neurological death in babies less than 37 weeks gestational age. Death is defined in the paediatric patient in the same way as an adult: an irreversible loss of the capacity of consciousness and an irreversible loss of the capacity to breathe. The preconditions described throughout this guide are the same. The tests should be completed in an unhurried manner, and time should be spent making sure that all the preconditions are met.
So this is the MR images of Harry Smith.
The tests should be carried out by 2 senior medical practitioners who've been registered for a minimum of 5 years, have been trained to carry out the tests, and are not members of the transplant team. Both should be paediatricians, and one of them should be a consultant. Neonatologists caring for newborn babies on neonatal units may require support from local paediatric neurologists or intensivists when making the diagnosis of death by neurological criteria. Regardless of where the infant is receiving his or her intensive care, it remains a requirement that 2 qualified practitioners complete 2 full sets of tests. As in adult practice, the testing of brainstem function in infants should be undertaken by the 2 doctors together and must always be performed independently, completely, and successfully on 2 occasions in total. Most units offer the parents the opportunity to observe the clinical tests, and it's important that they're supported and kept informed by an appropriate member of the team during the clinical examination if they choose to stay at the bedside. There's no evidence that any defined time period between testing is required. In summary, the preconditions detailed in the 2008 Academy of Medical Royal College's Code of Practice and also expressed in the less detailed 1991 British Paediatric Association document should be fulfilled before diagnosing death by neurological criteria in infants less than 2 months of age. The preconditions are as follows. The patient is comatose, apneic, and mechanically ventilated. There is a confirmed diagnosis of structural brain damage, or the immediate cause of the coma is known. All potential causes of reversible coma have been excluded. Drugs are not the cause. Neuromuscular blockade has been demonstrably reversed. Hypothermia does not exist. Core temperature is greater than 34 degrees C. And there's no evidence of potentially reversible circulatory, endocrine or metabolic disturbances that could be the primary cause of unresponsiveness. An additional precautionary precondition to be taken in infants less than 2 months of age is as follows. Infants who've been asphyxiated during birth or those successfully resuscitated after a cardiac arrest, regardless of whether or not they've undergone therapeutic hypothermia, must be observed for at least 24 hours, during which the preconditions necessary for the assessment of neurological death should be present before the clinical testing takes place. This is a mandatory recommendation. If there are concerns regarding residual effects of drugs, this period can and should be extended. The clinical test for the diagnosis of death by neurological criteria should only begin after both doctors undertaking the tests are satisfied that the preconditions have been met. The tests provide information about the integrity of the brainstem at various levels. The 2 doctors should work together not only to undertake the clinical tests, but also to ensure the preconditions are met. The same 2 doctors carry out both sets of tests. 2 complete sets of tests should always be undertaken, 1 set by each doctor. The clinical diagnosis and examination criteria used in adults and older children can and should be confidently used in infants from 37 weeks corrected gestational age up to 2 months post-term. The tests are as follows. The first is a pupillary reflex test.
Could somebody dim the lights for us, please?
The pupils should be fixed with no direct or consensual reflex to light. They do not need to be the same size or shape for the diagnosis to be made.
No reflex.
No, neither did I. Thank you. The lights can go back on now, please. Thank you.
Corneal reflexes should be absent bilaterally with no blink following stimulation of the cornea with gauze swab.
And I'm going to touch the colour bit of the eye on this side.
The cornea and not the sclera should be tested.
No response.
No motor response within the cranial nerve distribution should be present to a painful stimulus applied centrally.
See any movement?
No movement.
Spinal reflexes may persist and can be interpreted as such if peripheral movement occurs to peripheral stimulation. Peripheral movement to supraorbital stimulation is not a spinal reflex.
And now your toe on the other side. Just disconnect from ventilator. for me.
Suction down the endotracheal tube with a suitable length of catheter to stimulate the carina will demonstrate the absence of a cough reflex. Ensure that the suction catheter is long enough if the endotracheal tube has not been cut.
I'm going to put a spatula in the back of your mouth, Harry. Can you see to the back of his throat there?
Yes.
You can see.
Yep.
A Yanker sucker to suction both sides of the pharynx will demonstrate the absence of a gag reflex.
Seeing if there's any movement of the throat muscles or the chest or the tummy. And there isn't.
The vestibular ocular or caloric reflex is tested by initially examining the ear canals with an otoscope to ensure clear passage of cold water to the tympanic membrane.
Yep, that one's fine. You want to check your side?
The head should be flexed to 30 degrees to the horizontal. 20 to 50 mils of ice-cold water or saline should be injected through a quill into the external auditory meatus over 1 minute with the eyes held open. A receptacle can be used to collect the water as it leaves the ears. The eye should be observed over this minute.
Thank you.
Eye movements are typically nystagmus, but any movement in either eye means that the reflex is still present. The apnea test should always be the last test to be performed to avoid unnecessary hypercarbia if any previous tests have revealed reflexes to be
Am I
present.
doing the pre-apnea blood gas for us, please?
An important caveat in this age group is the hypercarbic stimulus to breathing should be higher before the testing clinicians can confidently establish that the infant is unable to breathe unaided.
Thank you, Liz.
Specifically, the PaCO2 levels should rise at least 2.7 kilopascals, 20 millimeters of mercury, above a baseline of at least 5.3 kilopascals, 40 millimeters of mercury, to at least 8 kilopascals, 60 millimeters of mercury, with no respiratory effort at this level. In practice, the actual apnea test should be completed in the same way as in older children.
Okay, so...
Cardiovascular stability should be preserved and significant hypoxia avoided.
If you could just set the oxygen up to, say, should we try 2 litres and see if that maintains adequate oxygenation?
Pre-oxygenate the infant and instill oxygen via a loose-fitting suction catheter at a rate of 2 to 6
Gonna
litres
carry
per
from
minute.
there. Good boy, Harry. Okay, thank you.
Alternatively, a T-piece or neopuff can be used.
Comfortable, you can see the baby's chest all right?
Yes.
Okay, should we start the clock now?
Yeah.
The infant's abdomen and chest should be exposed to ensure that any respiratory effort can be clearly observed. There should be no spontaneous respiration over the time period required for the infant's PCO2 to rise. It's recommended that the period of observation should be at least 5 minutes, provided hemodynamic stability can be maintained. The use of a respiratory monitor and end-tidal carbon dioxide may be helpful in detecting a breath. It's not uncommon to observe abdominal pulsation from the aorta during the test, and this can be confirmed by timing the pulsations with the ECG monitor.
Liz, that's been 5 minutes now. Would you do us another arterial blood gas, please?
Yeah.
Do you want me to hold
After
that for you?
5 minutes,
Yes, I do.
another arterial blood gas is taken to confirm a minimum carbon dioxide rise of 2.7 kilopascals. The infant is then reconnected and stabilised, and the arterial gases return to the infant baseline to prepare for a second test. Unlike the situation in the older child, ancillary tests in patients aged 37 weeks corrected gestational age to 2 months post-term are not sufficiently robust to help confidently diagnose neurological death. If a clinical diagnosis is not possible, death by neurological criteria cannot be made. Time of death is recorded at the time of completion of the first set of tests.